Welcome to the Doctor Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions and we will discuss it on our pod. Hello, everyone. This is Dr. Joshua Goldenberg and Dr. Adam Sadowski. Josh and Adam, your buddies for evidence evaluation and critical eval of the medical literature. And today, for God knows what reason, Adam has us reviewing an electronic cigarettes research article. I think this is the second electronic cigarettes research article you had us do. I think we did one a couple years ago.
So, what do you mean for God knows what reason?
Are people still smoking?
A lot of people still smoke.
People still can't be smoking.
Yes, Josh. Not only are a lot of people still smoking, but the youths are smoking.
The youths. Yeah, the youths.
These crazy millennials. These dag-nabbit.
That can't be a thing.
These dag-nabbit Gen Zers.
They're not smoking. No one's smoking anymore.
They're smoking e-cigs.
Oh, e-cigs.
It's like, they're like pacifiers, man. I'm not even joking.
Well, I think the last one we did was on like the potential dangers of e-cigs. I think for those like these concerns that people were going to like smoke that instead of smoking something else.
It was a Dr. Journal Club video. People should check it out actually, because a lot of people are kind of like,
oh, it was pre-pod. That's right.
It was pre-pod. Yeah, it was pre-pod. I think people should check it out. It was a good video. I like the article a lot. Basically, with that article, too long, didn't read. Spark notes of that study was that e-cigs are apparently appear to be safer from a quote-unquote toxicity standpoint with like regards to chemicals you're exposed to than cigarettes.
Right.
I mean, they're still new, right? There's still a lot to learn from them.
Right.
But the data is so clear that cigarettes are not good for you.
Well, but it's like this interesting. Okay, so it's been years, and Michelle, we're going to get you the link so you can put it in the show notes to that Dr. Journal Club review. But I kind of remember a discussion about like if it's compared to regular cigarettes, yeah, like safer. But like the fear is, well, what if people are picking up the habit from doing nothing? Like that's not good. And then like to look at that net, like what is that? How does that net out? I guess across society.
Yeah, and that the American Academy of Pediatrics way back when did have an article on this as well, where they basically, they were looking at adolescents who had no motivation or any interest in actually picking up cigarette smoking, and I think it was a cohort study, if I'm not mistaken, cohort or cross-sectional. I think it was cohort. And basically what happened was those who were not ever motivated to start smoking cigarettes, but did use the e-cigarettes. Again, this is in adolescents who aren't using e-cigarettes for smoking cessation. It's a different topic altogether.
Uh-huh.
There was, I think, a 4-fold increased risk in the then going on to actually picking up a smoking habit.
Yeah, so that's interesting.
So, if you're not doing it,
don't do this.
Don't start.
If you're doing it.
But if you're smoking cigarettes and the question is, hey, doc, should I, because this came up all the time. of, hey, should I go from smoking cigarettes to these vapes?
Mm-hmm.
And there were so many people who were saying like, no, smoking cigarettes is safer, which is the dumbest thing I've ever heard.
What? Oh, because it's quote unquote natural or something like that? Is that the idea?
I don't know, but it really annoyed me. And there's really high level evidence in Cochrane papers that support the transition from cigarettes to e-cigarettes. Now, granted, ideally you come off of e-cigarettes, but the whole goal is to get people to stop smoking.
Right. It's interesting. Have you ever smoked?
No.
I smoked for a while.
Really?
I smoked, when I was 18. I remember thinking like, I'm gonna be cool.
Were you the Marlboro Man? Did you walk around with a cowboy hat?
I was what was I? I think they were like they were Marlboro Lights, I think. They were like gold or something.
Oh, so they were safer for you.
Yeah. Well, I remember people having that conversation. Like when I was hanging out with the hippies, they'd be like, well, I only smoke, I can't remember the name of there's like a Native American brand or something. It's like all naturals.
American Spirits.
And that was the theory, is that like that was the healthy cigarette. I'm like, you've got to be kidding. You realize like we're all lying to ourselves, right? Anyway, but so you know what actually got me to quit smoking? I was thinking about this when I was reading the paper. I was like, it was so freaking hard, right? Like I knew how, first of all, I was like, why are we doing this? No one smokes anymore. And then I was like, well, it was really kind of hard to quit. Like I can see how it would be helpful.
I think you need to dip back into primary care and get a little dose of reality.
I know. That's. I knew you were going to say that. I knew you were going to say that. You're going to be like, well, you have to stop dealing with folks with SIBO all the time, and like that's all you see. Because you're right. I have no sense of what reality is. Um, but anyway, and I've got pretty good self control, but it was impossible to quit. It was so freaking hard, and I just remember I remember like getting so frustrated with myself and like breaking the cigarettes and throwing them in the trash, and then like, not making this up.
Then lighting the trash on fire and having a big old bonfire of cigarette.
I should have, because I would go back. I taped them together, Adam. Like it was such a powerful addiction. It's crazy. And the only thing that worked is I did my little hippie trip off to Central America for like, I don't know, I think I was gone a half year or something like that. And I was on a farm in Costa Rica with no access to anything, miles from the town. You couldn't go, and there was no store, and I ran out of cigarettes, and I couldn't do anything for like a number of weeks, and that's how I quit. Right? It was like, you physically need to be in a jungle somewhere and have no access to cigarettes, Josh, because apparently that's the level of self-control that you have. And that was really telling to me. This is powerful addiction stuff that we're talking about here.
Yeah. No, it's very tough. I've worked with people who use pretty intense illicit substances, and they say that the hardest thing to quit for them was the cigarettes.
That's crazy. I've heard that before, but that's like crazy that anecdotally you've been hearing that as well. Well, so this is interesting. So this is I was thinking about my history with this, because these folks were not like the kids you were talking about. These are folks in Finland who want to quit smoking, like poor Josh back in the day, have tried to quit smoking, even did a clinical trial to quit smoking and failed, were unsuccessful, and now we're like trying yet again. So these are people who are desperate to stop, and they need help, and that was the recruitment goal for this one.
Yeah, and it's also very clinically relevant because, oftentimes people have tried more than once to try quitting tobacco use, and so it's not an unreasonable inclusion criteria or population that we're dealing with. Like the main thing is like, okay, this is relatively homogenous patient population in that it's people from Finland.
Mm-hmm.
The fact that these are people who have tried to quit in the past and failed and are ready to go again, is very much clinically relevant.
I thought so too. I'm trying to remember the inclusion criteria. It was something like 30 pack year history. Like they had to be moderate or severe level nicotine addiction.
Yeah, they were smoking on a daily basis and are willing to quit. And these are people who were recruited back from 2003 to 2009 in that previous trial. And basically, if they were still smoking, were then allowed to come into this trial. And they had to be between the ages of 25 to 75 years of age. smoking daily for longer than 10 years with at least 10 cigarettes per day. There's 20 cigarettes in a pack, so they're smoking at least a half a pack a day.
Wow.
And they had to have been smoking at least a half a pack a day for the past 5 years. And they had to have a carbon monoxide level of 15 parts per million or greater when they were doing exhale testing. And the reason for that is because the primary outcome was not only self-reported smoking cessation success, but also parts per million of the carbon monoxide. And basically, if it was like under a certain threshold, then you can say like, yes, you have not been smoking. We can confirm biologically that what you're saying is truthful.
Yeah, it's always nice to have that objective marker. Well, let's zoom back out again. I mean, we're kind of jumping in a little bit, but we did a pretty decent job. So that was I think we did a good job with the inclusion criteria. So these are, like you said, very clinically relevant population. And then let's talk about the arms. It was a cool design there. It's a 3-arm trial.
Well, before we get into that, I mean, I did read the introduction to this.
Just always assume you didn't and move on, but go ahead. Yeah.
Well, I mean, again, sometimes I like to read it if it's an interesting topic or something that like, if the introduction reads well, I will kind of pay attention to it. Sometimes they're just like way out there, and I'm like, okay, this is going somewhere I don't want to get involved with. But basically, what they're saying is that they cited previous evidence that there is high certainty evidence that e-cigarettes that contain nicotine are associated with increased conventional cigarette smoking abstinence rates compared with nicotine replacement therapy. So that would be like your nicotine gums, your nicotine lozenges, patches, et cetera, et cetera.
So hold on, pause on that. Like, that's crazy to me. So you've got, let's just highlight that. First of all, very, very, very few things in medicine have high certainty evidence. Like, that's already very, very rare. And that's like grade level high. And so nicotine, so these are e-cigarettes with nicotine, and they have increased, first of all, your increased abstinence from cigarettes. So that's even surprising to me, and even more so than nicotine replacement therapy. That's great. That's impressive.
Yeah. And the evidence they cited was from the American Journal of Public Health and Cochrane. So not like little tiny trials, but pretty reputable journals.
So that's impressive. Okay, so we know that these e-cigarettes with nicotine are excellent for abstinence from regular cigarette smoking. Okay, deal. Keep it going.
Yep. And then they, continue to say like, hey, there's not a lot of there's no reported short-term adverse effects with it, but we do know that adverse effect reporting in clinical trials is miserable, and these just haven't been around long enough to develop, a solid database of long-term side effect profile of e-cigarettes.
Mm-hmm.
And so what they said was, in this study, the one that we're going to be podcasting about, was basically a 52-week follow-up where they looked at both effectiveness and harms of electronic cigarettes for smoking cessation compared to varenicline, which is brand name Chantix, in adults who were long-term smokers of conventional cigarettes. And for people who don't know, typically when it comes to medical therapy for smoking cessation, there aren't very many options. You have the nicotine replacement therapy, which can be like gums, lozenges, patches, a combination of those. You have bupropion, which can be used, and then you also have varenicline, which is brand name Chantix. Chantix is known for causing vivid dreams, and there used to be concern.
Oh,
Yeah, there used to be concern that it could cause or induce or result in psychosis, and so it kind of had this like for a second there it had a black box warning.
That's not good.
But then after the Eagles trial, which actually looked to investigate this, the FDA then subsequently removed that psychosis black box warning. They showed that there was actually no significant increased risk in the development of that in with Chantix use compared to placebo. So then they removed that label.
Good background. Okay.
Yeah, so that's just some background information with regards to that.
And it's I think this is right. It's a partial like nicotinic receptor agonist, right?
Who cares?
Well, I think that's the well, just with this thought, who cares? I knew you were going to say that.
No, but seriously, no. But seriously, who cares?
Well, I mean, it kind of makes sense. You sort of like agonize. You sort of like tickle the nicotine receptor, and it's gonna.
Hey, Josh, cool. Are you still smoking? Nobody cares. Nobody cares. Stop.
We have people on this pod who care about mechanism of action. Thank you very much.
That's the problem. Stop. Yeah, cool. We have mechanisms of actions, and like we can use that and be nerdy, and like yes, it is important, but clinically, I want you to stop smoking.
Okay, that's fair. That's fair, especially with like high level evidence. Like, I don't know what the evidence level is for Chantix, but it's one thing to say, okay, we've got like this one tiny little trial, like we're hanging our hat too much on or too little on mechanism of action to explain it. But if it is solid evidence, like, yeah, you're right. At the end of the day, who cares how it works as long as it works?
Right.
Okay.
Okay. And so then basically what they did in the prior trials was looking.
I'm going to have all these benchtop scientists come after us. Yeah, go ahead. Mm-hmm.
All right, so come after us. Come after us, give us your data.
You don't want to mess with rat people. Rat people are serious. I mean, let me tell you. I don't know we could take the Elijah people, but rat scientists, I'm not sure. All right, keep on going.
As good as the rat from Teenage Mutant Ninja Turtles.
So this has been killing me. Is that Shredder, or there's Shredder and there's
No, I thought Shredder was the bad dude.
Okay, so that's what I couldn't remember. There was a bad dude and a good dude.
Yeah, the good one takes in the Teenage Mutant Ninja Turtles.
Right, but that's not Shredder. It was Shredder, but there was another S name. It wasn't
Sadowski.
That's what we'll call you. Adam the Shredder Sadowski. Dr. Adam the Shredder Sadowski.
Okay. All right. We're going on a tangent. Okay. All right.
I hid the tangent. Did you like that? Normally we tangent at the beginning. This is an interpod tangent to fool our listeners. Okay, go ahead. Keep on going.
Okay. So the primary outcome of that last trial where they recruited these patients from, the primary outcome was 7-day smoking abstinence. So self-reported of, hey, I haven't smoked in the past week, which is great. And then they also confirmed it with carbon monoxide on exhalation. And that was at the 26-week mark. So basically after 6 months of follow-up.
So solid outcomes.
Yeah, and then for this trial, because there was no previous randomized controlled trials that looking at e-cigarettes compared to Chantix or varenicline, and we don't get any sort of compensation for saying it. It's just easier to say Chantix, and that's what most people know it by. Yeah, so we're not getting sponsored by big Chantix here.
We're not part of the Chantix lobby.
And so what they hypothesized in this trial was that if varenicline or Chantix therapy were to be combined with motivational interviewing, then the success rate of smoking cessation would increase compared to nicotine-containing e-cigarettes combined with motivational interviewing. So they're kind of comparing Chantix plus motivational interviewing to e-cigarettes plus motivational interviewing.
Which is standard of, like, I would imagine, you tell me, you're the primary care doc, but like that would be standard, right? Like we know motivational interviewing technique works, I assume, and that's sort of like you add that to whatever other intervention you're doing. So it's not like they were trying to get this thing to win. They were like setting it up as it would be in real life.
Yeah. And again, because they're really trying to maximize therapeutic benefit here. So ideally you're doing motivational interviewing with your patients, but reality sets in and sometimes you can't.
Wait, did the placebo groups also get the motivational interviewing?
Yeah, they got.
Oh, they got it too. Okay.
Yep, they got placebo in this trial. They got placebo Chantix, placebo e-cigarettes plus motivational interviewing.
Okay, so they're maximizing the benefit, but they're not trying to juice the difference of the study, because even the placebo group got maximum potential placebo effects and motivational interviewing. Okay, gotcha. I'm with you now.
Yeah, and so to go back to your earlier point, what were the three groups in this trial? You had the e-cigarette group plus placebo Chantix plus motivational interviewing.
E-cigarette, placebo Chantix, and motivational interviewing. Okay, yep. Mm-hmm.
The Chantix group had placebo e-cigarette. So That was an e-cigarette without any nicotine content, but looked exactly like the actual e-cigarette with nicotine. Plus, they got motivational interviewing, and then, as we just said, placebo had placebo everything but real motivational interviewing.
Yeah, so like double dummy, we would sometimes call that, plus
Yes.
motivational interviewing. Okay, awesome. I like those groups. Very nice.
Yes. And the people who were using the e-cigarettes were allowed to use it ad libitum, which I liked, because basically they said, here is your e-cigarette supplies, do what you will with it.
Right.
Because that's how people are doing it in real life. No one's really like, oh, you can only smoke 2 milliliters of liquid, blah, 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 blah.
Well, and that's also kind of like an intervention in and of itself, right? Like sort of like a taper or something like that.
Yeah.
Yeah.
And the study design was really cool. I liked it. It was an investigator-initiated, randomized, placebo-controlled, single-center clinical trial. So they're very clear here, and I really liked how they reported this. So it's a randomized, placebo-controlled trial. We all know what that is. Single-center meaning it was only done at one university, and then investigator-initiated meaning basically these investigators all got together and were like, "Hey, we should do a trial on this." And they were like, yes, we agree, let's go do it. And it's independent of industry sponsorship.
Right. It's not an e-cig study.
Correct. Now, that being said, they did disclose, and they were very clear about this, that the trial was funded by Grand, which was a grant, and with financial support from Pfizer.
Okay.
However, the funding organization, i.e. Pfizer, had no role in the design, conduct of the study, collection, management, analysis, interpretation of the data, preparation, review, approval of the manuscript, decision to submit. So basically, they just gave them money and supplies and said, like, here you go, like, figure it out.
So just to clarify, they make Chantix. So they did have an incentive, but like you said, they crossed their T's, dotted their I's as far as their involvement.
Yeah, but also, even though they had an incentive, they could have, should the data show that Chantix was terrible and got blown out of the water, that was a risk that they were willing to take. So
yeah, I'm cool with that.
Yep. I think, yeah. So for everyone who's kind of like, oh, industry sponsorship is bad, not really. Like, read through the details.
Not these days. It's cleaner these days. You have to be careful. I think supplement industry is still a bit of a mess, but
it's terrible.
Yeah. But they're getting better.
And then the e-cigarettes were purchased with the grant.
Okay.
So yeah. Okay. So cool.
All right. I'm with you. Keep on going.
So very low risk of bias there for anyone paying attention or interested.
Well, let's talk about risk of bias super fast. So everybody was blinded. The design said it was good, but just they did have a mention about masking, and I was just thinking about that. Like, it would seem pretty obvious to me. I would imagine if you're smoking an e-cigarette and you don't taste the nicotine, right? Like that, I feel like that would feel different. And so
I thought everything was identical. So in flavor and everything.
Yeah, but you're smoking non-nicotine. I mean, it's going to be different. I mean, it looks the same, but then you start smoking it, and if you're used to nicotine, are you not going to notice that it doesn't taste like nicotine? I don't know. I just feel like
I've never smoked nicotine, so I don't know.
Well, this is why I bring my deep knowledge base to this pod on these important matters. I feel like it would be obvious. And they do mention the potential risk of unmasking. So it was blinded, but you can always be unmasked, right? If like you just like, wait, there's no way this is nicotine. Or like we've talked about, if you're blinded and then you start having lavender flavored burps, you're like, there's no way this isn't the lavender pills. But what they noted is that there was no difference in dropout rates, and so they were kind of using that as a proxy. Like if you felt like, okay, I was getting the placebo cigarette, maybe you would drop out more, right? So I don't know. Well, that was something they brought up, but they didn't seem too concerned about, just because they didn't see unequal dropout, I guess.
Yeah, I feel like it's a bit of a reach too.
Yeah, I'm all right with it. I'm totally right. And it's also more realistic, right? Because, I mean, this is designed to show efficacy, not effectiveness. But in real life, like, you're going to know if you're having an e-cigarette without nicotine.
Okay.
Look, the thing is, we don't do this for money. This is pro bono. And quite honestly, the mothership kind of ekes it out every month or so, right? So we do this because we care about this. We think it's important. We think that integrating evidence-based medicine and integrative medicine is essential. And there just aren't other resources out there. The moment we find something that does it better, we'll probably drop it. We're busy folks. But right now, this is what's out there. Unfortunately, that's it. And so we're going to keep on fighting that good fight. And if you believe in that, if you believe in intellectual honesty in the profession, in integrative medicine, and being an integrative provider and bringing that into the integrative space, please help us. And you can help us by becoming a member on Dr. Journal Club. If you're in need of continuing education credits, take our NANCIAC approved courses. We have ethics courses, pharmacy courses, general courses. Interact with us on social media, listen to the podcast, rate our podcast, tell your friends. These are all ways that you can sort of help support the cause.
And so, yeah, they randomized the participants with computer-generated randomization scheme. Everyone was 1-to-1-to-1. And then participants, nurses making personal contact, people providing the motivational interviewing, and then the researchers assessing the outcomes and analyzing the data were all masked, meaning they were blinded. And then an external statistician from a different university did the randomization scheme. So super clean.
All good. Very kosher. Yeah, very clean.
What exactly did they do? Each group went through 12-week intervention, which makes sense because Chantix is prescribed for a 12-week course.
Oh, okay. Mm-hmm.
Yeah. And then an observation period of up to 52 weeks. So for a year.
Really nice. Really nice.
Yeah. And then the primary outcome was essentially assessed at the 6-month mark. And then the secondary outcome was assessed at the 1-year mark. When it came to motivational interviewing, it was 8 sessions of individualized counseling for 30 minutes.
Seems reasonable to me. Yeah. And it's balanced across groups anyway.
Yep. And then with that primary outcome, it was 7-day abstinence that was self-reported and confirmed via exhaled carbon monoxide levels of less than 10 parts per million. And then they basically did the same thing at the 52-week mark.
Oh, and that helps us with unmasking. If it was unmasked and that influence, well, let me think this through for a second. It's an objective outcome. So, well, I guess it would be like if you're lying about. Yeah, never mind. Keep on going. We're still good.
Yeah. And then secondary outcomes were viewed as exploratory. So really, it's mostly about the primary outcome at the 6-month mark, not the 52-week mark.
But it's nice that they have that follow-up. Yeah.
Yep. And then everyone was randomized to the group they were assigned in. So the intention to treat protocol, which we love to see. And then that was really it from a method standpoint. I really like the way that this study was conducted and reported.
Yeah, one thing I wanted to add, which makes it even better, is so it's one thing to say like intention to treat principle, like what does that mean for the people that actually are missing outcome? So for losses to follow up, they assumed they kept on smoking, which is great. So they basically had a worst case assumption about missing outcome data or loss to follow up, which is a very conservative way to do it as opposed to multiple imputation or coming up with all sorts of different sensitivity analyses, which is what we usually do. They actually just assumed the worst. And if they were missing an outcome, missing to follow up, they just assumed they were still smoking. So so any difference that you would see would be a conservative difference there.
Yep. Okay. Do we want to jump over to what the baseline demographics were of this trial?
Yeah, let's do some baseline stuff briefly, and then let's jump into the results. So baseline, we've got a pretty even split between male and female, more female than male.
Nominally more female than male, which I thought was really interesting.
Surprising, right? You would think the opposite, or maybe not. I don't know.
By about 10%.
Yeah.
55 versus 45.
Yep. So mostly female, but not like crazy skew. Average age about 50 years of age. Average BMI 26, 27, 28. So, overweight. And average years of smoking 33, 34 years of smoking. So balance, that's a lot.
That's a lot. That's a really hard group to then get smoking cessation with.
That's right. 30. Yeah, let's just take a second there. That's 3 decades of smoking. That's a strong addiction. And like you pointed out earlier, they've tried multiple times to quit. They've even been involved in clinical trials to quit before and failed. So they're very motivated. They're showing up again to quit.
Yep. And then about 64% have smoked at least half a pack, so 11 to 20 cigarettes per day. And then about a third, 30% or so, smoked even more than a pack, so about a pack and a half, 21 to 30 cigarettes. And then you have some who are smoking even more than that, and that was about 4 to 5% of people who smoked at least 30 cigarettes per day.
Yeah. Okay, good. So that's our population. Like you said, a little bit only maybe concerned with homogeny because it's all from Finland, but still it's a really good trial. And I like the population. It seems very appropriate for primary care. Good. Okay. I think the only other thing I want to mention about that was the use of what they call snus.
That's like snuff. That's like chewing tobacco.
Okay, that's what I thought. I had to Google it because I was like, is that different than the little pouches? So it is the little pouches. And I think that's so relevant because essentially, like, they have this objective marker of carbon dioxide level. But if you're getting your nicotine another way, you could basically be making up for it. And it would appear as if you had quit, when still you're just as addicted to nicotine. So I thought it was great that they were so cautious about that. And it did not seem to influence results one way or another.
Yeah, and the Gen Zers love to use what's called Zyn pouches, ZYN.
Oh no, is that a thing?
It's just nicotine pouches. They seem to be pretty addictive. Yeah.
So that's a thing. That's so interesting. I was like,
Josh, you're so out of touch.
I know. Doesn't it cause like holes in your gums or something like that? I just remember. Anyway, the whole thing's not good. Don't start smoking. Okay, so can we talk about results? Can we jump into results yet?
Yeah.
Okay, cool. So here we go. So the main outcome here. So we're talking about confirmed abstinence at 6 months. So the e-cigarette group, we have, so this is like true nicotine e-cigarettes with placebo, Chantix, and the motivational interviewing. 40.4% were abstinent at 6 months. That's remarkable, I would think. 40% of this tough population is abstinent at 6 months. That's outstanding. The Chantix group was 43.8, so a little bit higher, also outstanding. And the placebo group was 19.7. So 1 in 5 people on just, well, it's say just placebo. Remember, they had motivational interviewing as well. 20% of them essentially quit, which is amazing at 6 months. And then you had double that essentially with the e-cigs with nicotine or the Chantix. Which is pretty cool. There was a statistically significant difference, clearly, with those numbers between the e-cigs versus placebo and the Chantix versus placebo, but not between Chantix and e-cigs. The difference was too close. So we can't say statistically that even though Chantix nominally had a higher abstinence rate, that may just kind of be random error when compared to e-cigs. But both seem to be very effective versus placebo or motivational interviewing alone.
Yeah, you might even argue that this is a negative trial for Pfizer.
Why?
In the sense that, you know, e-cigarettes may be as effective as Chantix.
Oh, that's true. Yeah, so nominally better, but right, maybe statistically the same as e-cigs. That's right. But definitely reinforces this idea that it doubles the response rate versus placebo. Yeah, good point. Okay.
But it's really important because, I mean, it's important clinically because now it's like, hey, here's a fourth option that we can consider.
Yes. Yeah, that's right. That's right. Love that. Okay, what else did I want to say? I think that's it for the 6 month outcome. Should we talk about the 1 year?
Yeah. Let's talk about the 1 year, which, remember, was a secondary outcome and viewed as exploratory. And was a little bit upsetting.
Yeah.
Because at the 52-week mark, we basically showed about, I don't know, close to 50% like a, I don't know, 30% reduction in the number of people from the 6 month mark who were abstinent at 52. So remember, confirmed abstinence was biological in addition to self-report. And at the 52-week mark, we have 28% in the nicotine electronic cigarette group, versus 38% in the Chantix versus 20% in the placebo. So placebo basically went unchanged. The Chantix group dropped off from 44 to 38%, rounding up, and then the nicotine group dropped off from 40 to 28%.
Yeah, so
Chantix did a little bit better.
Yeah, and was statistically significant still at 1 year, whereas e-cigs were not.
Yeah.
Barely. Interesting. So we have at 6 months they're about equivalent, both double the placebo response, and at 1 year we see that the Chantix has held most of the benefits, still statistically significant, whereas the e-cigs have dropped, no longer statistically significant when compared to placebo.
I love how they reported the absolute change in the difference too, within on the bottom of table 2.
Yeah.
So yeah, at the
Mm-hmm.
at the self-reported and confirmed abstinence, when you look at the confidence intervals for the e-cigarettes, it went from -1 to 18%. So no difference there. And then for the Chantix group, it was 8.4. Or let's say 8%. Let's round up 8% to 28% was the 95% confidence interval there. So that remains statistically significant. And then placebo was also -1% to 20%. So it crossed that threshold of no significance.
Yes. And the other interesting thing just about the snuff or zing or zang or whatever you called it,
Zin.
even when you look at that at 1 year, the results are analogous, where it's barely not statistically significant with e-cigs, still statistically significant for Chantix, and then the difference between the two is not statistically significant at the 1 year mark. Now remember, it's the 6 month mark. E-cigs are still doing well, but yeah, they kind of lose their. It's interesting that the e-cigs would lose their benefits, some of their benefits at 1 year, whereas Chantix would not. Because if it's just a 12-week, were they taking Chantix all the way through, or just for those 12 weeks?
Just for those 12 weeks is my understanding.
Interesting, very interesting.
Now, perhaps this is where the bench scientists come out from their gremlin hole and start talking to me about this is why mechanism of action matters, is because perhaps there's something here that would explain that.
Perhaps.
But again, I don't care.
Oh, man. Beautiful. I thought it was a very clear study. I don't think...
Wait, we're not done. We're not done.
Yeah. Well, what else was there to talk about? Side effects?
Adverse effects. Yes.
No adverse effects. No adverse effects. I guess that's something to talk about.
Some people died.
Not many.
Oh my God. Oh, dear listener, when we see Josh in the lawsuit, and they say, Dr. Goldenberg, you have killed some patients, and Dr. Goldenberg's response will be, yeah, but not many.
It's all about the absolute effects here.
It's not statistically significant, Your Honor.
Yeah.
Yeah, Your Honor, it was a non-statistically significant increased number of participants who died under my care.
Well, that's essentially what happened here. We see a couple of people die each group.
Yeah, 4 people died in total, 2 in the e-cig group, 2 in the placebo. Neither were related to intervention. There were really no significant side effects for all of these, with the exception of Chantix had nausea. That was statistically significant, and that was basically it.
Well, so one other thing, I didn't catch this before. Look at the part. So we're in table 3, listeners. Adverse events leading to discontinuation of a study treatment. The Chantix group was double the amount in the e-cig or placebo. That's interesting.
But they also had higher success rates overall, which was also interesting.
So
explain that, bench scientist.
So you're more likely to get side effects significant enough that you would stop your treatment if you're taking Chantix, but overall, you are still more likely to benefit particularly at 1 year, and just as likely at 6 months. Interesting. Okay, so we might expect higher side effect rates with the Chantix. That's useful information. Whereas the e-cig, I mean, I'm not surprised that the e-cig is the same as placebo. I mean, they've been smoking cigarettes and now they're just smoking electronic cigarettes. Like I would be surprised if there was much of a difference. I mean, maybe you get shocked by this e-cigarette. I don't know if that's the thing, but probably not.
Well, there were E-Valley concerns. So I forget what E-Valley totally stands for, but it's like
E-Valley?
Yeah, it's like e-cigarette vaping associated lung injury, something like that.
Oh.
These were early concerns back when e-cigarettes first came to market, and a lot of it had to do with people tampering with the combustible.
Oh.
And so a lot of people were getting like into like ICU admits for pretty severe pulmonary injury from the e-cigarette tampering.
Okay, so that would be a good thing to look here. We're not seeing an increase with these. Okay, beautiful. What else? Anything else you want to talk about?
I thought the discussion was interesting. I kind of agreed with them that they showed that they said not only was Chantix helpful, but so was the e-cigarettes at 6 months, and then they just kind of talked about the lack of evidence that kind of exists looking at e-cigarettes and whatnot, but that kind of they're off to a good start with this what's available right now and the direction that the research is heading in.
Yeah. It's interesting in actually looking at the data versus what they said. I'm actually more impressed with Chantix the second time through here because of the 1 year mark. But it's funny because like apparently Pfizer gave them a bunch of funding, but you don't get that sense from reading their article. They just make them seem like they're equivalent, which is interesting. So yeah, clearly they didn't have an overly impressive influence on the authors. If anything, it seems the opposite. They kind of downplayed the Chantix benefits. Interesting. Okay, cool. I like it. Now, just to reinforce, the big debate, I think, is what is the population that you're giving e-cigs to, right? Like if you're giving it, like you said in that first study you were talking about, where people that had no initial interest and they're young and now they're going to start smoking whatever, it's not good compared to nothing. But if they're like hardcore smokers for 30 years and have tried everything to quit, like, yeah, it's kind of an obvious no-brainer. But so it really does matter. Like, it seems like this debate gets, at least a couple of years ago, it was like a big debate. Like, are these e-cig things brilliant or harmful and horrible? And it really depends on the population, I think, is the take home.
Context matters a lot.
Context matters. Yeah. Yep. So if you're in Finland and you've been smoking for 30 years and you've tried a bunch of other stuff, you might try e-cigs or Chantix and you might double your chance of abstinence, which is super cool. All right. I like that little study. It's not that little. It's about 500 people, 150 in each group. Nice job, Adam. Thanks for recommending that one. Any last minute words of wisdom to our listeners, sir?
Well, yeah, although it was a small study, given
small study, 500 people
relative to like other studies that are like large, right? it was a long term. It was relatively long term, a year.
Yeah, year outcomes. Mm-hmm.
Very well conducted.
Yep, agreed.
Seems like we've now got 2 high level evidence papers.
Mm-hmm.
Do we need another study?
I mean, I don't think so.
If we did it, if we repeated it in, let's say, a different patient population, even if it was like a homogenous patient population, let's say like in Australia, right? Or let's say we did another one in the States.
Mm-hmm.
And we get the same results. Would you be like, hey, I think we're done here? Or would you want to continue beating this like crazy, like a vitamin D trial?
I mean, I don't even know that they needed this one. So they had high level evidence for what? They had high certainty evidence that nicotine containing e-cigarettes are associated with an improved smoking abstinence. So, I mean, they already before this was even done, there was high level grade evidence that you're going to increase your abstinence with e-cigarettes compared to nicotine replacement therapy. So the debate is, okay, well, what about compared to Chantix, which is not nicotine replacement? But I guess like for the point of should you try e-cigs, they already have that data. Like grade high by definition literally means that any future study is extremely unlikely to change the overall result.
And it's really cool. It's cool to see that confirmed here.
Yeah.
Hey, yeah.
That's true.
I think that's cool.
Yeah, that's the idea.
Because you read about that. Yeah, that's the idea of like, hey, if it's high level of evidence, really nothing should change.
But you always wonder.
But I haven't seen. Yeah, you always wonder, and like I haven't really seen like okay, like they say it's high level, but we're gonna do another trial, and then confirming that. Like I just haven't stumbled upon it. Whereas this was like, hey, there's high level of evidence, we're gonna repeat it, and yeah, we found the same thing.
Yeah, it is interesting. Like when they were setting up the rationale in the introduction, when you already have high level evidence of something, it's like, well, what's your rationale? And their spin was in the like having this additional arm for Chantix. But yeah, as far as actual e-cigs, yeah, it's already there. And to your point, like I think we don't see that a lot because in theory, you shouldn't be running extra trials and wasting resources if you already know it's high level evidence. But also, very few things are high level evidence, right? Like we've done some papers like that. I can't remember what the percentage is, but it's in the low single digits, isn't it? Like things that are effective and high level evidence in medicine.
We're probably like 4% best.
Yeah, right. It was something I remember that somewhere between 4 and 7. I can't remember, but like absurdly low. And so this is one of those rare things where e-cigs apparently are in that fancy group of high level evidence and efficacious. So I am impressed. But don't start if you're a little kid who has no interest in starting to smoke. Only if you're Finnish and have 30 years of smoking.
E-cigs and Viagra.
Well, what's the evidence on Viagra? It's high level?
The number needed to treat is like 2.
Is it? So
yeah.
Okay, that's interesting. And it's and the evidence level's high?
It works for yeah.
Okay, interesting. All right.
I'm assuming. I'm pretty sure it is.
You're assuming.
I'm assuming.
They have a good lobby, apparently. It's interesting. I would love to see a list of the interventions that are high level and efficacious, and a large effect size. Like here, we double the response rate, right? Like I would love to. That's got to be a rarefied list.
It's like 3 items:
cigarettes and Viagra. What's the third? I wonder what semaglutide, GLP-1s.
Oh, it would probably be Suboxone.
It might. Is the level of evidence high for Suboxone?
Don't quote me on that. I'm going to assume yes. I know the number needed to treat is very low with Suboxone.
Oh, that's interesting.
But it's likely high level of evidence.
Huh. Very curious.
I'm assuming. Don't quote me. It's not medical advice. I don't know. I'm telling you outwardly, I do not know.
If you're a listener and, you know what? There's another one. Mark's always talking about it. It's probiotics for...
ulcerative colitis.
No, not even. For some pediatric...
Oh my God.
Necrotizing something or other, I think, that has high-level evidence. Mark's always like, it's one of the few things that has high-level evidence. And it's true. Okay, so we got Viagra, probiotics in that one pediatric population, and e-cigs. And then listeners, if you've got any others, please send it our way. That would be cool to kind of make a list and maybe do a series of papers where we talk about the things that actually work, since we're always fetching about the things that don't work and how most things don't. So it might be a nice little tweak.
Our 2-episode series, things that work in medicine.
We've already covered them, right? Yeah. All right. Well, we're not jaded. Okay. Well, we'll talk to you later, listeners. Thank you, Adam. Good paper at the end of all my complaining. It was a good paper, and it was interesting to know that we have high-level evidence for that. So cool, man.
Yeah. Step back into primary care and
never.
The world is your oyster.
All right. Talk to y'all later. Bye. If you enjoy this podcast, chances are that one of your colleagues and friends probably would as well. Please do us a favor and let them know about the podcast. And if you have a little bit of extra time, even just a few seconds, if you could rate us and review us on Apple Podcast or any other distributor, it would be greatly appreciated. It would mean a lot to us and help get the word out to other people that would really enjoy our content. Thank you. Hey, y'all, this is Josh. We talked about some really interesting stuff today. I think one of the things we're going to do that's relevant, there is a course we have on Dr. Journal Club called the EBM Boot Camp that's really meant for clinicians to sort of help them understand how to critically evaluate the literature, et cetera, et cetera. Some of the things that we've been talking about today. Go ahead and check out the show notes link. We're going to link to it directly. I think it might be of interest. Don't forget to follow us on social and interact with us on social media at Dr. Journal Club, DR Journal Club on Twitter. We're on Facebook, we're on LinkedIn, et cetera, et cetera. So please reach out to us. We always love to talk to our fans and our listeners. If you have any specific questions you'd like to ask us about research, evidence, being a clinician, et cetera, don't hesitate to ask. And then, of course, if you have any topics that you'd like us to cover on the pod, please let us know as well.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.